If you pop a hole right here in your neck and put a tube in there directly into your lungs, all your problems with snoring go away immediately, and you have a whole new set of problems, like drowning when you take a shower and not being able to talk to your wife.
Exactly. Patients get inundated with the term obstructive sleep apnea, or sleep apnea in general. And obviously, most of the time when we're talking about sleep apnea, it's actually obstructive sleep apnea. So, Dr. Ben, give us an idea. So what's the formal definition? And what's kind of the definition that our audience can relate to and wrap their brains around?
Yeah, great. So this has all been a progression over the last 40 years. I mean, I started med school 32 years ago. I know you've been doing this a long time too, and it's changed over the decades. Right now, it's a progressive weakening of the structures of the back of the throat, usually mixed with a nasal obstruction. But it has definitions on sleep study too. So it's the number of times per hour that you stop breathing and drop your oxygen a certain amount on a sleep study, 5 being that sort of unique number that says the dividing line between quote-unquote normal and sleep apnea. So if you do it more than 5 times an hour, it's sleep apnea. If it's more than 15, it's moderate. More than 30, is severe. And that's based on outcome studies, most notable of which there was a big study done in the VA network, the NISQIP data set back in the early 2000s by Ed Weaver. He was my mentor at University of Washington, and they basically just looked at people that had sleep apnea that were untreated. And that and other studies sort of defined those categories, mild, moderate, and severe, into risk of what do you develop, do you die early, and if you die early, what do you die from? They also, Dr. Weaver also was able to determine that if you, by the way, that study was incredible because it was an odds ratio of 4 that you're going to die early. What that means for the geeks out there is that's massive. That's 400, that's 4 times the risk for an early death from chronic disease. But if you treat it effectively, that risk is all wiped out. So one of the things for causality, and as you know, is that you have to have, if something's causing something to happen, you have to prove that it happens, right? Not just a correlation, it happens in the presence of that thing. So chronic disease and an early death happens when you have sleep apnea. And also has to sort of meet that metric of when I remove that thing, does it make it go away? And it satisfies that. So we knew early on in the late 90s and early 2000s that sleep apnea was causing a lot of problems, and the treatment of it was really important. If you think of it in terms of what we call technically a Starling resistor, for all those folks out there that are engineers or have a bent towards physics. But in general, you can think of it like a paper straw that you stick in Sprite. Everybody knows that. So if you stick a paper straw into your Sprite, you suck on it, it works great. 15 minutes later, the straw has changed over time. That's what we mean when we say progressive weakening. It's changed over time, and you go to suck on it, and everybody's been frustrated when it collapses on you. So it's important to remember those two things. Your throat is like that paper straw, and over time, it's changing.
Ben, that's one of the best ways to discuss and explain what happens that I've quite frankly ever heard. Because I
always say that to my patients.
Yeah, I've never heard that in a talk from anyone or anything like that. You know, they'll throw out Starling resistor and that kind of thing. Who the heck knows what that is? Most doctors don't know what that is. But kind of the way you described it, how the straw, how it gets wet over time and it becomes more pliable, and then all of a sudden when you're sucking in, it's collapsing on you. That's really great. Tell us, you know, how do I know when the person next to me it might have sleep apnea? What's the technical definition, so to speak, of what's happening? How many times does it have to happen for me to get worried? That type of thing.
So quite often, 40% of America snores, as you know, and so that's the first alarm bell that you're changing. So I always tell my patients, when I walk in, I'm not 18 years old because I have gray beard and some wrinkles. And you don't have to be a doctor to recognize those changes in the face. How do you recognize the gray hair of the throat? The gray hair of the throat is the snoring, so it's the sound. So the first thing that starts happening when that straw in your throat, right, starts to get weaker is that it's no longer able to stay open when you take a full breath of air, especially depending on how open your nose is. So snoring is the first sign. Not everybody who snores has sleep apnea. And so how do you know when it's starting to change? Snoring is quite loud, and obstruction is quiet. You start to take pauses when you're breathing. So quite often, family members will come in and say, well, he was snoring, but lately he's been pausing and then taking gasps. That's a good indication that it's starting to get worse and starting to decompensate and might be time for a sleep study. When you have a sleep study, when you go to a professional, either a sleep doctor, and there are many types of those, or an ENT who's focused on sleep, they're going to do a sleep study on you where they actually look at you over 1 or 2 or 3 nights, and they put some sensors on you that can tell how low your oxygen goes and how long these pauses are. And so what we look at is the data from those sleep studies. And if you pause and drop your oxygen in a defined way more than 5 times in an hour, that's sleep apnea. More than 30 times in an hour is severe. And so a qualified professional will take that information and talk to you about what category you're in. Treatment is sort of laid out based on risk, and the risk is stratified in mild, moderate, and severe. That risk, of course, Lee, is what we're all talking about. What happens to you if you do nothing about it? And so,
so for our audience, basically, what sleep apnea is a cessation of breathing. You stop breathing despite trying to breathe. So you're trying to breathe, but there's an obstruction, and the air stops flowing. So it could stop flowing completely, or it could stop flowing partially, and you can get a drop in your oxygen saturation because of it.
First of all, you don't know how great it is to have this fixed. So whatever the treatment is, go and seek it, because once it's fixed, it literally is like somebody flips a light on in a dark cave. You suddenly get your life back. You get jettisoned back 20 years, and you wake up feeling great. So that's the first thing. But you're not doomed to a mask. There's 4 basic categories of things that are traditional treatments. There's also some big ones on the horizon that we didn't see coming 20 years ago.
Why is sleep apnea bad? Well, we know obviously it disrupts sleep, and therefore it disrupts your bed partner, it disrupts your sleep. You're more tired when you wake up in the morning, not just because you haven't had enough sleep, and we'll go in on other episodes as to why that is, but what does it cause? What's the risk that it causes? High blood pressure, type 2 diabetes, weight gain, central obesity. So let's move to obesity, because I can't tell you how many times I see a patient in the office and they say they went to their primary care physician, and their primary care physician told them, look, just lose weight, you'll be fine. Okay? Many times they don't even do a sleep study. They just say, I'll just lose weight, you'll be fine. Other times they do the sleep study and they say, just lose weight, you'll be fine. Tell us 2 things. Tell us first why they're wrong. Okay, in terms of that the obesity is the defining issue in their sleep apnea. And number 2, tell us why it's not so easy for those people to lose weight.
Yeah, so you're getting right to the heart of it, and that's great, because I can tell you that the patient population is pretty varied, and it's not exact. So not everybody who's obese has sleep apnea. Not everyone who has sleep apnea is obese, but it is linearly correlated. What does that mean? Well, it means as your sleep apnea gets worse, you're more likely to be overweight. But it's not a lot. So at its highest amount in severe sleep apnea, it's about 60% of people are overweight. But down in the mild and moderate range, it's only about 30 and then 40%. It does get higher. You tend to be heavier the worse your sleep apnea gets. But this is the most telling thing, though, and this is what everyone needs to realize, is that the weight starts first. There are the sleep heart study, the multiple studies out there that show most people's weight starts to go up before the sleep apnea starts. And to your point, what happens once you start to get heavy? Well, you just say to yourself, well, why don't I just try and lose weight? Once you have sleep apnea, a couple of major things start to happen. Remember, sleep apnea is about interrupting your sleep. Most specifically, the slow wave sleep, the REM sleep, the sleep that makes us feel good in the morning. In order to have a good night's sleep, you got to go into slow wave sleep and have multiple episodes of REM during the night. That's when your body relaxes the most, and that's when your throat closes the most.
Okay, so people have heard about REM. Tell us what REM is.
That's the rapid eye movement. That's the part of sleep where your brain goes through certain processes that make you feel rested in the morning. Your brain has to go through this in order to wake up feeling refreshed.
Just so people know, the reason that our muscles all relax during REM sleep is our dream level of sleep, right?
Yeah.
So we don't want to act out our dreams, right? You don't want to be dreaming of going off the cliff, and next thing you know, you're leaving your house and then jumping off a cliff.
I've done a lot of facial trauma in my career on people that have had REM disorder where they don't go into a relaxed state. They act out their dreams, and they've done terrible things. One guy about 5 years ago, he was a high diver in college, and his wife saw him get up, walk to the end of the bed, and face plant. He dove off the end of the bed and smashed his face. And so it is an emergency. I mean, people do things that hurt themselves and others when they're doing this. So you have to relax, and your body needs to go through that. But when you do, sleep apneics close their throat, and that fractionates their sleep. It breaks it up. So what happens when you break up your sleep? Well, one of the first things that happens is that your growth hormone burst that happens between midnight and 4 a.m. goes away. Almost immediately, actually. And that's responsible for most of the growth hormone during your day. So, and the other thing that causes a cascade of events hormonally inside your body that changes your basal metabolic rate. So we know that growth hormone, everybody knows growth hormone. Yeah, you're short if you don't have it. It does so much more than that. It's the master hormone of your body. It basically tells your body how to utilize energy. Every single one of our 37 trillion cells in a male, 35 in a female, has a receptor for it. So we know also that it tells the mitochondria inside those cells to utilize fat instead of sugar. So it fundamentally changes how you use energy. And then there's a couple of other hormones you should probably know. That's leptin and ghrelin. Ghrelin starts to become very high. It's basically telling your body, because your body's feeling like it's in a fight or flight mode all the time when you wake up after not having a good night's sleep, it wants to get you eating to get your energy up. And so you start snacking a little more, maybe grab an energy drink, and so you have high ghrelin. The other one, leptin, ghrelin and leptin, you guys have probably heard of all of this. It gets thrown around the internet all the time. You become leptin insensitive. So these two hormones are kind of complicated, the way they interact, but hormonally inside, it makes it so that you can't lose weight. And then you get into a vicious cycle. Because if I have sleep apnea and it's untreated and I go out and walk a mile, even if I'm probably too tired to do that, but if I can go out and work out, I walk a mile and you walk a mile, I'll lose nothing, you'll lose a pound. So the person that has sleep apnea is now no longer able to lose weight as well, and their weight goes up, and of course that makes sleep apnea worse.
The thing that I tell patients that really astonishes them is that when you gain weight, you actually deposit fat in your tongue, in the muscles around your neck. The actual muscles themselves get fat deposits. And when you get fat deposits in those muscles, the muscles don't work as efficiently, right? So it puts extra bulk, extra weight on those muscles. That narrows the airway. The tongue gets more fat. That narrows the airway. And that's a big issue, because when we're talking about the diameter of the airway, we're talking about, at times, depending on what we're dealing with, a game of centimeters, if not millimeters, in terms of the collapse of the airway. We talked about cardiac effects, right? So the heart is a muscle. If our oxygen saturation is dropping while we're sleeping at night, our heart has to pump harder and faster to get the same amount of oxygen to our tissues. What happens? The heart's a muscle, like any muscle. It starts thickening. The problem is it doesn't thicken outward, it thickens inward. So the chamber gets smaller. And as the chamber gets smaller, what does our heart have to do? Pump harder, faster to get the same amount of blood out to the tissues. Vicious cycle. Eventually the heart fails. So congestive heart failure, increased risk of stroke. These are the reasons that if you think you have sleep apnea, if you think your bed partner has sleep apnea, if you think your cousin Harold has sleep apnea, make sure that they go get it checked. Now, Dr. Ben, going and getting it checked by just anyone, primary care physician versus pulmonologist, versus ENT surgeon that is schooled in sleep apnea and sleep surgery.
So this is an interesting thing. There are some fantastic, competent sleep docs out there that come usually from pulmonology, cardiology, neurology. Those are the main contributors to it. There's some family practice.
And just explain what
folks.
those specialties are for people.
So cardiology deals mostly with the heart, and they're concerned with it for the reasons that Dr. Lee just said. Neurologists are interested in it because of the stroke, dementia aspect of it, the brain fog. And the pulmonologists, obviously, because of the effects on the lung and the fact that it's a breathing issue. So medicine in the U.S. is pretty territorial, wouldn't you say? I mean, we've all got our own little fiefdoms, and they're governed by our own private companies. Usually they start with the American Academy of. But they all have guidelines, and those guidelines overlap pretty well. I will tell you that if you go to somebody who is a neurologist, cardiologist, pulmonologist, a sleep physician, they are fantastic at this. They will tease apart not just sleep apnea, but insomnia if you have it. And they'll determine whether or not it's narcolepsy. They'll do a lot of those things. But adding in the idea that a well-trained sleep ENT and a head and neck guy, ear, nose, and throat trained surgeon who also does sleep, like Dr. Lee and I, adds the additional idea that they're going to address the nasal airway. The reason this is important is that quite often what will happen, and I hear this from patients all the time, they go into this excellent sleep expert. They get diagnosed with sleep apnea. They immediately set them up for their CPAP mask, and then they send them home with this mask with very little instruction, and the person fails it. 50 to 80% of people will fail the CPAP mask in the first year, and yet it's the gold standard. That is a dismal gold standard, if you ask me.
And those that use their CPAP mask only use it about 50% of the night, right?
Right. And so again, I mean, it's great. It's great to have a CPAP at home, but if it sits in the drawer, it's not helping. I think everybody can kind of recognize that. There are several studies, many studies actually, that have shown that most people that are failing it fail it because they have a nasal obstruction or something around the nasal obstruction. One of the ways to know, I can tell you because I have severe sleep apnea, and I was unaware of how bad my nose was. I'm an ENT. You talk about the levels of denial that it takes to kind of go through this and not understand what's happening to you. I hear ENT docs sometimes saying, well, I asked him if he breathes through his nose well, and he said yes. That's not adequate. Most people who have a lifelong nasal obstruction have no idea.
Believe believe it or not, some studies out there where they experimentally completely occluded the nose in humans and induced sleep apnea just by complete nasal obstruction.
Almost immediately.
Right, but you and I both know that the average person coming into the office, you're not going to cure them of sleep apnea just by fixing their nasal obstruction issue.
Yeah, it's a 3-level problem in general.
Right. So let's get into first of all, into that and what we do gain in terms of benefit when we improve nasal airflow, both the direct effects, as we were saying, on the change in the pressure, but also downstream effects like effects on ability to tolerate CPAP and oral appliances and those types of things. And second, what types of procedures and what types of things are we looking at in terms of correcting when we're talking about the nasal airway?
Yeah, so I mean that's a big topic, really, but you can break it down to this: it's a 3-level problem: the nose, the palate, and the tongue. If you have a pipe that's blocked in 3 areas and you unblock it in 2, you still have a blocked pipe, and it's important to remember. So when I talk to folks, the first thing that I do is get a CT scan and/or a scope to take a look inside the nose. Usually, if they're coming in with no sleep study, I get a sleep study cooking. We're going to find out what's happening to the palate and tongue. Do they have sleep apnea, mild, moderate, severe? But I get the CT scan and take a look objectively. Are there big narrow points here? Is it moderate to severe deviated septum? Is there nasal valve collapse? Are there large turbinates? Are there large adenoids? And I try and maximize the nasal airway. A lot of people are afraid to have nasal surgery, and so they're kind of like Quint at the end of Jaws, where they're sliding down into the jaws of the shark, and they do not want to say anything that's going to get them a nasal surgery. But things have changed, and nasal surgery is actually quite simple, relatively pain-free, and easy to recover from. And so I try to dissuade people's fear of this to open up and talk to me about it so that I can help correct it. Typically, what you're going to see is a deviated septum correction, a septoplasty, a turbinate reduction, something to help with the nasal valves. And we can talk about that because I know you have a great way of doing that, and so do I. They're very different, though. But we want to open that nose up, even if it's just to help them wear a CPAP mask better or use an appliance. But remember, if you're wearing an appliance and it locks your mouth shut and you don't breathe well through your nose, you're going to struggle. You're going to wind up taking it out. If you put a CPAP mask on your face and it feels like it's suffocating you, typically that means that you have a nasal obstruction.
You touched on very briefly, but it's very, very important, the idea of nasal valve collapse, which most, even general ear, nose, and throat physicians don't really have a grasp of. Dr. Ben and I are both board-certified facial plastic and reconstructive surgeons, and so we're very, very familiar with not only nasal valve collapse, but how to treat nasal valve collapse. The nasal valve is the area, this kind of soft area right here, right above the nostrils, right about right there, okay? And if you just gently pinch the very top part of your nose like that, and you try and breathe through your nose, you can see it really makes a huge, huge difference in your airflow. So that's one area. There's another area, and a friend of both of ours, Pete Catalano out of Boston, did a great paper on doing a very, very small procedure near where the openings go into the sinuses to improve that airflow. And these days, a lot of times we do those with balloon catheters and that type of thing. And he found a statistically significant improvement in AHI, or apnea-hypopnea index. Basically, sleep apnea got better in just doing that procedure. So there are a lot of different areas in the nose we don't really even understand why it's having such a positive effect. We do know that we need to have a certain amount of resistance, nasal resistance, in order to completely expand our lungs. So when we breathe through our mouth, right? If people breathe through their mouth, they tend to hyperventilate after a period of time. Why is that? Because you can't completely expand your lungs because you're not breathing in against enough resistance. So the small airways.
One of the things also to remember, though, Lee, is that most of the nitric oxide produced in the body is produced in the nose. And so that nitric oxide helps expand those little pockets, the alveoli in the edge of the lungs. And if you're breathing through your mouth, you're getting none of it. So you take this huge nitric oxide producer and you take it out of the circuit, and that immediately makes the lungs a little bit less compliant. But you're right. It's also, again, back to the physics of this, where you got to have a little bit of back pressure in order for the lungs to fully expand.
And the point of that is, we'll call this the vital point of the day, right? Is that not all surgeons that do what we do it the same.
The Iwata study showed that most people that fail the CPAP mask are failing it because nobody checked their nose and they have a nasal obstruction. And then when you fix that nasal obstruction, 100% of those people, actually no, 40, I believe it was 47 of the 50 were able to then wear a CPAP mask, and 3 of them were actually cured of their sleep apnea. So it's a little bit misleading when people don't do well in it. So how can it be a gold standard? Well, if you properly assess the nasal airway, remember that these people can wear the CPAP mask. It does work, and it's cheap and easy to use. So if it's cheap, easy to use, and effective, that qualifies as a gold standard. Again, the caveat is that a lot of people fail it, but they fail it for reasons that are preventable. So make sure that you're looking that you're talking to docs as a team. You're not just going to one sleep doctor who tests you, you're positive for sleep apnea, slaps a mask on you, and you're out the door. Typically, you want somebody to evaluate. Certainly, if you come back and say, when I put my mask on, I feel like it's suffocating me, and you want to try and be seen by a doctor that's going to help you tease that apart. That's not the way CPAP should feel. You might be one of those people with a nasal obstruction. So yeah, it's a gold standard. I mean, you can say that it is. It's got an asterisk though, right? It's not like all these treatments. They're treatments with an asterisk. The asterisk for CPAP is that.
That's assuming that the CPAP machine isn't leaching carcinogenic materials into your airway.
Right. Yeah. So, I mean, yeah, obviously, one of the companies that made sleep apnea machines, it was found that it was actually causing a cancer in people's lungs because of the deterioration of the materials it was using. They're fortunately off the market now, but yeah.
So we hit CPAP. What's next up?
Well, the stimulators. So look, stimulators are all the rage. By the way, I'm maybe a little bit biased. I was the first one to implant a stimulator in the state of Texas successfully, and I've done probably more than anybody here. Stimulators, I think, are the future of this. Look, you have the definition of sleep apnea, again, is a progressive weakening of the structures of the back of the throat mixed with a nasal obstruction over time. Progressive weakening over time in humans is kind of analogous to aging. It's aging, right? So it's how we age. It gets worse with time. There are some other factors like obesity and some lifestyle issues, but in general, you're getting worse over time. And so if you get floppy and fall back and block your throat, it makes sense that you add stimulation back. When are you getting floppy? Are you getting floppy during the day? No. You're getting floppy when you try to go through deep wave sleep, slow wave sleep at night. Your REM stages, the restorative part of your sleep cycle, requires that you get relaxed. And when you do, when a sleep apneic does, the palate and tongue fall back, block the throat, and cause obstruction and cause your oxygen to drop. Well, stimulators like Genio, the new one that goes under the chin, and Inspire, which has 2 incisions. We should talk about these two because they provide stimulation precisely at that time in your sleep cycle when you're collapsing and disrupting your sleep. So in my opinion, it is precisely undoing what the problem behind sleep apnea is, and that is obstruction at the time of restorative sleep.
Now, I want everyone to understand that not all surgeons that use these implants, that insert these implants, are created equal. Okay? So it is very, very surgeon dependent. You have to tease out which branches of the nerve you're going to actually stimulate.
Well, that's for one, right? So that's for Inspire.
For Inspire.
Yeah, so for Genio, it's a little bit different. And I should also say Genio has just been FDA approved, I think 3 months ago. And so only 800 or so have been done worldwide. I have never done one. I've done cadaver lab dissections on them. So I've done thousands of surgeries like you have in this area because we're both head and neck surgeon trained. But I haven't actually put one in. You don't have to tease apart. Actually, we should talk about the differences between Genio and Inspire real quickly.
Yeah, and I have done Genio.
You have. That's right. You were one of the first guys. You're one of the first 800.
Right. So Genio is much more of a non-specific stimulation. So it doesn't get down to the specific nerve branches. And
it kind of does though, right? Because it's after the separation. You're getting it midline. The big thing with Genio is it's bilateral.
Right. And that's what I was going to say. The difference, how it makes up for it, is because it's bilateral.
But the branches have already separated. Once it comes into the midline, the exclusion branches separate themselves out and go superior.
Right.
Right. And so you just lay it across this already anatomically separate branch. You lay them across it,
which is easier said than done.
Easier said than done. Yeah.
Because it's just a paddle that sits on it. You're not actually wrapping a cuff.
Now, when you did it, you used the older one that was larger. The newer one is very small, and the paddles sit a little bit better. We probably there's another doc in town that's done a few of them already. I haven't done any yet. So I was the first Inspire. He's the first Genio now, but he's only done a few. So what's the difference between the difference between Genio is bilateral.
For people that don't understand medical terminology, that means both sides, bilateral.
Both sides, yeah. And it's done through a single incision with no chest incision because the battery is separate. So you do have to wear a sticky device that holds the battery, and the battery communicates through the skin and provides power externally to the internal device.
And the good part about that, just to interject, is that with the Inspire, for example, you are actually inserting the battery, okay?
So the battery sits in a separate incision for now, a separate incision down on the chest.
And that battery has a life to it, has a finite life to it. And when that finite life is up, you have to replace it.
We think it's somewhere around 12 years. Yeah, we think it's and by the way, when you replace it, I've replaced one before. It literally takes about 15 minutes. It's a very small local procedure. You just make a little stab incision, you pop it out, pop a new one in. So it's pretty simple to do the replacement. And I have a lot of history with Inspire. I think it's a great company. I think they're doing incredible the research and advancements on their product, which I commend them for. Every iteration is getting better and better. The 5 that's out now is smaller, smarter. It no longer needs a sensor for the lung. It works on an accelerometer. An accelerometer is inside that battery pack that times it. Genio is not timed with your breathing. Genio just has a it has a pretty good correlation, but only about 85%, whereas Inspire is precisely timed with your breathing through this little device, this accelerometer that can sense your breathing. So the sensors inside Inspire are extremely advanced, and so its success rate in my hands is about 94 to 96%. Nationwide, it's 79%. That's what's quoted on the ADHERE study. What is it doing? It's stimulating. There's 56 branches of this nerve in your neck called the hypoglossal nerve. I tease out the anterior 18 branches and put a cuff around it.
Anterior means the ones towards the front.
Yeah. So there's a subset of ones. And what do? They pull your tongue forward, right? They raise it up in the mouth and they stiffen the tongue. So they basically open the back of the throat. But if you're looking down from the nose from above, it actually opens and works on the palate as well. So that you'll see the palate and the tongue and everything, the whole airway expand open. And it does it in a very profound way. But in general, the opening to the airway is profound during an awake endoscopy. And it's timed with your breathing. So when you inspire, that's where they get the name. When you inspire, the airway is unfettered. Again, you need a good nasal airway or it won't work.
I deal a lot more in oral appliances than I do in stimulation therapy. And one of the things that I say to patients to kind of help them understand what's going on is that if you're wearing an oral appliance and I want to get the airflow behind your tongue, right? If you're not breathing well through your nose, then you might start breathing through your mouth, even though you're wearing an oral appliance. Now, wearing an oral appliance, it doesn't mean that you can't get airflow through your mouth. Your lips can open. If you start breathing through your mouth with an oral appliance, what does it do? It sucks your tongue back. Makes it worse instead of better. So I have patients that come that went to the sleep dentist, and the sleep dentist made amazing oral appliance. They did a great job, but they don't tolerate it, or it's actually making it worse instead of better, and that's because their nasal obstruction was never dealt with. The other thing that I see is patients, especially with severe sleep apnea, that are wearing full face masks. Full face masks are not the easiest thing in the world to tolerate. I'll tell you that right now.
Especially the ones that are over the nose.
Right. And so what ends up happening is someone that has nasal obstruction, most of the air when it's being pushed through a full face mask is actually going through the mouth instead of the nose. You require much higher pressures to force air around the tongue than through a nose. And so the pressures go up, the tolerance goes down.
Also, they're terrible to wear. They're just horrible to wear. You feel like you're a fighter pilot. I mean, you can't see anything. It's hard to watch TV. But by the way, just so you know, what he's talking about, a full face mask is anything that goes around the mouth. There are full face masks that go under the nose and lift it up. The ones that go over the nose are the worst. The ones that go under the nose, a little bit better, but still kind of bulky.
Yeah, so I'm particularly talking about the ones that go over the nose and the mouth, the real big full face masks.
Yeah, anything that goes around the mouth is considered full face, even if it goes below the nose. I wear one. I wear an F40. So, but that's because it's a choice, because the one that goes over the nose is just terrible. Then it tends to close the nose more.
And ideally, I find that nasal pillows are the most tolerable. So nasal pillows just got their cushions that go inside the nose, or actually just right at the opening of the nose, and the air goes through that way. So many times we'll be doing nasal procedures to improve the nasal airflow so that we can switch someone from a full face mask, which they don't tolerate, to nasal pillows, which they can tolerate. So a lot of different things that improving nasal airflow and reducing nasal obstruction can help us with in terms of treating sleep apnea.
I have 3 dentists that work with me pretty regularly. I have 2 neurologists that are sleep board certified that work with it, because there are some not all problems are obstructive sleep apnea. People have multiple sleep problems who come in. Some of them have insomnia that needs to be teased apart and treated before you do this. Some of them have narcolepsy. Some of them have different types of central sleep apnea and things. All this needs to be dealt with, and Inspire makes sure that you are looking at the entire patient, which is very rare for a company. So there are a subset of people that wind up just getting a mouth guard. I fix their nose, and they want to go the level of the mouth guard. And for moderate sleep apnea, that's a very viable thing to do. So you should probably talk a little bit about mandibular advancements devices, Lee, MADs.
Yeah. So I'll go into a couple of different areas with this. The first is that a mandibular advancement device is basically a mouthpiece that's put in your mouth that goes on the upper teeth and the lower teeth. And there's usually a little kind of ratchet on it. And that ratchet allows you to determine how far forward the lower jaw goes and how open the lower jaw goes. So when you see these these different mandibular appliances or sleep apnea mouthpieces that are advertised over the counter, where you can just purchase it online or you can purchase it at a store, and you throw it in some boiling water and put it on your teeth, and it's supposed to mold to your teeth, and then it's supposed to cure your snoring or sleep apnea. Most of the time, in my experience, they don't work. And they don't work for several reasons. Number one, even though it's boil and bite and it should fit your dentition properly, usually it doesn't fit your dentition as well as if it's made by a dentist, and specifically a dentist that does sleep dentistry. So that's number one. Number two, these devices do various different things. One of them sucks the tongue forward. Sucking the tongue forward doesn't do anything if you don't have room for the tongue to go. Okay, that's the problem, is the tongue usually is overly large for the space that it's in, and it's falling back. If you try and suck it forward, it does absolutely nothing. The second thing is, all it does is ratchet forward. Okay, so if all you do is ratchet forward the lower jaw, the tongue is coming forward with it, but it's just hitting the front teeth, and then it's cantering backwards. Okay, so it's really doing nothing for you just to go forward. You have to go forward, and you have to have some mouth opening as well. With that mouth opening, as you ratchet forward, the tongue actually has space to fall into. And I even find many dentists don't understand this completely. The sleep dentists that I refer to, they do a great job at using diagnostic tools to determine exactly how the airway is expanding when they're using the oral appliance, and that makes a huge difference in terms of the effect.
I mean, they're just like us, though, Lee. I mean, there are ENTs that don't understand sleep. I'm sure that there are dentists that don't understand sleep because that's not what they do. You know, but they might want to get into the game because you can sell these appliances. But if they're not really dedicating their lives and their knowledge and their learning to sleep, they might have some deficits in their knowledge.
So I would say, from that perspective, you know, the vital discourse, idea of the day here, if I was going to put one out, at least as it pertains to this, is that if you are thinking about, or someone has recommended an oral appliance, go to a dentist that does sleep, that specializes in sleep dentistry, to have your oral appliance made. You'll have the greatest chance that oral appliance will actually have the effect that you want it to have.
The great cure, the four categories that we were talking about that do cure the palate and tongue portion of sleep apnea after you've opened the nose. CPAP mask, real easy to use as long as your nose works. Very easy, cheap, and effective. Stimulator therapy. I happen to think the stimulators are the future of sleep apnea treatment. They're going to get better. They're going to get smaller. They're going to get much more accurate. Right now, they're Inspire and Genio. Lots of companies coming into that space. There are a lot of great technology coming out. Surgical interventions by OMFS doctors, by ENT doctors, head and neck surgeons, to trim the palate, tongue, and move the bones forward. And then the mandibular advancement devices, the devices that pull the jaw forward. Those are the four sort of vetted ways that we treat this. What else, Lee? What am I forgetting?
I think you rounded it out beautifully. So everyone, thank you so much for listening in, watching if you're watching. And this ends this episode of Vital Discourse. Can't wait to see you next time.